I'm a community endocrinologist, so I work at LMC in Brampton, but I also have this research and public health domains that I try to dabble in, and maybe some of that we can discuss as we go along. Here's my disclosures. So in terms of learning objectives, what my focus is going to be is what is the interplay between diabetes and cognitive dysfunction as well as mood disorders, primarily mood disorders, and outline what the mood disorders associated with diabetes, how they affect the general well-being as well as the risk of complications. How does that play out in real life? Also about identifying these comorbid conditions together or screening for them, and then talk about some of the management approaches that we will talk about. I'm a clinician first, and this is how I'm going to start. So this was the symposia that Roger just pointed out, that me and him and a family doctor were part of together. This was a role play, so it was not just a CME, it was actually a role play with an actor playing a patient as well, so it was kind of cool, out of the box, right? An actor came in and talked to the physician, basically a family physician, with new diagnosis of diabetes, so that you can see the timeline, right? 8 years ago, new diagnosis of diabetes. 7 years ago, diabetes distress started. And then 2 years ago was when actual depression may have started, in addition to some of the complications of diabetes, which we recognized more often, and depression maybe goes unnoticed at times. And then just last month, this patient had a foot ulcer that actually resulted in a foot amputation as well. And that led to a malpractice lawsuit. And so that's how this case was played out. I'm not going to play this out. I'm a bad actor. I'm not going to even try to do that. What I'm going to do is actually focus on that diabetes distress aspect, which was 7 years ago in this case, as well as the depression aspect, which was about 2 years ago in this case, and maybe come up together, all of us can come up together as to what should be the approach in terms of strategizing to get across these patients, and then help them as an interactive, as a interdisciplinary team, if you will, is going to be the focus. So this was a case. Let's think of somebody who's newly diagnosed, basically, is how we should start about thinking about this case as. So 54-year-old comes in, newly diagnosed with type 2 diabetes. And he's had diabetes for about 6 months. He has no cardiovascular disease history, no other comorbidities at this time. His BMI, as you'd expect, is overweight. His blood pressure is okay. A1C is 7.5. That's how you're diagnosing a patient with diabetes. And of course, what we do is we talk about lifestyle, and then we give him medications, right? So that's what was done for this patient, which is metformin, which is titrated to 2 grams a day in divided doses, as well as a statin medication to protect the heart as well. Now, this is, this scenario plays out so many times in physician offices. But sometimes, to think about it from a person perspective, what is going through their mind is something that we sometimes overlook or we don't think about. When you think about, you give them a diagnosis and tell them you have diabetes. Diabetes is a permanent disease. So when we say that word, chronic disease or permanent disease, what goes through them in their mind? Do they think, oh, I'm going to die from this? Is it something severe? How is it going to affect me? How is it going to affect me physically, but also how is it going to affect me in my mental health as well? So that's something that gets overlooked many of the times. The other thing is diabetes, as we treat this, we are actually just waiting for complications to happen, waiting for the problems to get worse, and then treat it more aggressively. As was pointed out in the previous talks, that maybe in terms of depression, prevention is not discussed as much. But even in diabetes, we're not talking about prevention. We're not. I mean, when we are in clinic as a clinician, we are basically waiting for the complications to happen and then start treating them aggressively, whereas what is lost is the first few years of diabetes diagnosis. Why is that? because diabetes is a silent disease. We know that. It's a silent disease until it starts showing complications. But it's a very complicated disease at the same time, and we miss that pathophysiology aspect of it. So if I were to ask you a question, is type 2 diabetes a simple disease or a complicated disease, what would you answer? How many of you would say it's a simple disease? Of course, I've already spiked this question, right? It's a complicated disease. Why is it complicated? It's complicated because of many of the psychosocial issues that go along with it, but it's also complicated from pathophysiological standpoint as well. So this is the pathophysiology of type 2 diabetes, what we now call the ominous octet of diabetes, the different organ systems that diabetes includes. So if you, at the top, you have glucose production from the liver, and then beta cell, of course, those are the two organs that are mainly even from 20, 30 years ago, we know that these are the two organ systems that are really involved. In the beta cell, the insulin production as well as glucagon production are the culprits. But it's not just static insulin deficiency. It's actually a progressive deficiency of insulin over time with diabetes as well. So it's not just a static disease. It's not just a silent disease. It actually progresses over time. And that's the beta cell dysfunction that progresses over time. So the pathophysiology of diabetes actually keeps changing as people grow older with diabetes as well. So it's a very complicated kind of pathophysiology. And I've just started talking about 2 of the organ systems. There's actually 6 more that are involved in the pathophysiology. I won't bore you with details of each of those, but one of those is the brain. The neurotransmitter dysfunction, of course, is interrelated to the pathophysiology of diabetes, but also what happens once diabetes gets diagnosed as well. In terms of complications or comorbidities, this is another point to say that diabetes is a complicated disease. If you look at this kind of EMR database, in the UK, this is a UK primary care patient database of 1.75 million patients. What they found was, if you look at the diabetes row, which is right here, how many of the comorbid conditions are there when a patient walks into your office with diabetes? So you can see many of them have coronary heart disease, hypertension, heart failure. If you go to the last column, it points out there is about 6 to 7 comorbid conditions with diabetes that a patient is walking in with. So it's a very complicated kind of situation. That's an average of 6 to 7 other disease states that the patient is walking in with. In relation to this lecture, how about depression? So how many percentage of patients with diabetes walking into your clinic may have depression? It's about 18% in this UK database as well. So about 20% of those, 1/5 of those may actually have depression according to this and some other literature as well. So it's quite common among those patients. Sometimes it is under-recognized as well, and that's the issue. So it's a very complicated kind of pathophysiology, and there's a lot of comorbid conditions. Of course, there's complications that are associated with that. But the question is, how do we treat this? How do we treat, what is the current paradigm of diabetes management? And this is something that I'm very familiar with because we've studied this. So this was a study that we did called NADIR study. This is patients in their early diabetes in the clinic who are seeing their primary care physicians. So we looked at the red line is the at referral line, and we looked back at their A1C levels over the past 6-7 years. We can do OLIS search, right? All of us use OLIS now, and what we found was the mean A1C was about 8.5 during this time period. So it was nowhere close to 7 or 6.5 from the beginning of diabetes or early diabetes. And what was staggering was also the fact that despite having 11 years of diabetes, only about a quarter of these patients had actually been to a diabetes education center. So we're saying it's a very complicated disease. There's pathophysiology. There's, of course, socio-psychological factors that are involved. But then diabetes education, and this is in the GTA, where there's a lot of diabetes education resources that are available, are underutilized in early diabetes. And why is that a problem? Because that sets the stage for a lot of later problems, including mental illness that comes with diabetes as well. So of course, I'm going to show you what happened to these patients after they were referred. I'm showing you this just for completion's sake. I'm not saying that every patient should be referred to a specialist. What I try to emphasize is that the bubble that you have, the 28% diabetes education program attendance in the first 10 to 11 years of diabetes, that needs to be changed, because it has been clearly shown that a team environment, which includes a dietitian, a nurse, a pharmacist, educating the patient alongside the physician is very, very important right from the word go when the diagnosis of diabetes is made. Now, this is just a pictorial of what we are talking about. So this is, there's two ways of treating early diabetes, and that's shown in the green, right? So the green line, it goes down from an A1C of 8.5% to under 7%, and that's the early aggressive intervention that you can get. Well, what ends up happening, just like our Nadir study, and it has been shown in multiple other studies as well, is the purple or the red line at the top. The long-standing poor glycemia, the A1C comes down, but then it keeps creeping up until something drastic happens. And what is that drastic thing? Some complication, microalbuminuria, it could be a stroke, it could be an amputation. So something has to happen, and then the A1C starts coming down, and it's already too late is what the problem is. That's early diabetes that is the problem. So the early diabetes leads to, poor control of early diabetes leads to, of course, complications. But I think more importantly, what it leads to is bad glycemic legacy. Of course, that's what is leading to the complication, but also bad psychological legacy as well. What do I mean by that? What I mean by that is when you have a newly diagnosed patient with diabetes, you say, it's a chronic disease, and some people actually start believing that it's a lifestyle disease. They also start thinking that it's my own fault as well, that I brought this on myself. And then they start thinking, oh, I need to change this, I need to change this. They try their best, and we try to help them as well. But then it's a disease. By the time diagnosis of diabetes has happened, all those 8 organ systems that I showed you have already been involved. And we try, we should be trying to get them on medications like metformin, other medications that can bring that A1C down for this disease, but that's not always done in a timely manner. And what ends up happening is, most of the time, the patients are fluctuating between 8 to 8.5 all the time for the first 10 years of diabetes. And then when the complications start happening, we say, oh, now we got to bring it down to the 7%. And that's, the patient in their mind, I'm not sure if they bring it up to you or not. In their mind, they're thinking, oh, for 10 years, I've had diabetes. My A1C was 8, 8.5. Or if they know about their A1C, if they don't know, they'll say my sugars when I was testing were around that mark. But all of a sudden, now I have to change. And they've built this physiological dependence on hyperglycemia, as well as this psychological barrier as well. So that's where I think we're losing the game, or losing the clinical impact of early diabetes management as such. So what can we do? What can we do to change this? I think diabetes education is a must. So this, again, is a Nadir study looking at people who attended diabetes education versus who did not attend diabetes education. What you can see is, even those people who are high A1C, they actually do better as well in terms of bringing down that A1C. Now, this Nadir study was just any comers. We looked at all comers, all people who were referred to LMC. Within LMC, we also have done specific studies in more challenging patients. And these are more challenging patients who actually been in endocrinology centers for a long time, not just freshly referred, but also within the endocrinology clinics. So our clinic, there are patients who are more challenging than others, and not in terms of challenging you, but challenging in terms of their socioeconomic or psychological or mental illnesses, right? So that's the challenging patient that I'm talking about. In that patient, what we need is not just even regular diabetes education, but even more impactful, maybe individualized interventions with the diabetes educators. And that's what we did in this study, which was published a couple of years ago, called Drop A1C. In this, the LMC patients, they were given intervention in terms of social support, in terms of psychotherapy, in terms of managing or helping them manage or educate about their diabetes even more on an individual basis. And even in these challenging patients, there was an A1C reduction, which was much more compared to, say, the standard of care, which is the source cohort that you can see in this bar graph. And this is not just an LMC-based program. You've seen this similar kind of research in any country, any city that you look at. So here's a couple of others. So team care interventions versus usual primary care. What happens to patients if we do a team care approach? They do better on their A1C, LDL. So the intervention group is in blue versus the standard of care in red, and you see better A1C, LDL, blood pressure, but also their depression scores or SCL20 score in this study that was better as well. And here's another kind of meta-analysis looking at this, that what these people did was looked at all the studies, combined them in a meta-analysis format, and saw if the team care approach was better or not. Was what their question was. And what they found was, in people especially who have depression and diabetes, as I said, maybe 10 to 20% of people may have that. And in those people, the depression scores were better, as well as A1C was better by 0.3% as well. So team care approach is necessary for every patient with diabetes, but especially maybe for those patients who have depression on top of diabetes as well. Here's a kind of a pictorial of all of that. So what we've discussed until now is this team care approach, and this is taken from the Diabetes Canada guidelines, which just came out just last month. I'm not sure if you're familiar or you follow those guidelines. But one of the major things, one of the major emphasis in the guidelines is about structure of that team that needs to surround the patient that is in the middle, that is the you. So you is a patient, and surrounding that should include their physician, should include their nurse, should include the dietitian and the pharmacist, so that the same kind of education messages can be surrounded, can be provided to the patient, and they get the right message right from the word go, right from diabetes diagnosis, and they don't have to depend on Dr. Google. They don't have to depend on their neighbor to get the information, because that's what is happening if we don't provide them that right education right from the beginning as well. The outer circle is people, healthcare providers, who may be needed for certain individuals. For example, a heart specialist may be needed if somebody has a heart condition. Similarly, a mental health professional may be needed for people who have mental illnesses in addition to diabetes as well. So that's the outer circle that should be individualized. But the central circle, the middle circle, is for everybody, and that should include some of the psychological kind of interventions as well. When we talk about psychosocial interventions, and this is again from the guideline, this should be for everybody that should be integrated into the diabetes care plan. And we as physicians are not the only ones doing it. It's actually the nurse, the dietitian, and the pharmacist. Maybe incorporate them in that psychosocial intervention as well. What are the techniques? The techniques are motivational interventions, stress management strategies, coping skills training, as well as family therapy or case management. Depending on the patient, you can decide which one of these applies, but this should be not just be treated as a disease that you brought it on, you have to do better. It's actually a disease that from the beginning, we should be thinking of how can we help the patient better manage this disease in a team environment so that they can actually prevent the complications as well as the stresses that comes with this disease as well. So that's what Diabetes Canada guidelines are suggesting for each and every patient with diabetes, whether they have been diagnosed or don't have been diagnosed. with a mental illness as such. So this is kind of like standard of care should be that, is what the Diabetes Canada recommendations are. I'm going to switch focus now, and I'm going to go into more of diabetes and mental illness for those people who then have mental illness. I said between maybe 15 to 20% of people may have depression. Some of them may have other mental illnesses. It's actually maybe going out a little bit from my comfort zone as well, because I'm a diabetes specialist. I'm happy to talk about diabetes, what is pathophysiology is, what is management should be, or the goals of targets of therapy, or the complications. But then talking more about maybe what this symposia, this today's educational venture is all about, is the combination. Where do diabetes and mental illnesses kind of meet, and what are the interrelationships in that? So again, I'm going to take you to this Diabetes Canada slide from the guidelines itself. In the mental illness chapter in the Diabetes Canada guideline, this is kind of a pictorial of the interplay between diabetes, major depressive disorders, as well as some other psychiatric disorders. As you can see, in the middle is a major depressive disorder. You have the black, the other black is diabetes as well. And then towards the sides, towards the corners, are the white boxes that talk about some of the psychological kind of issues that go along with this, and some of these maybe maladaptive personality traits, stress, general anxiety disorder, feeding disorder, eating disorders, also the sleep-wake disorders. And then on the right side is the bipolar, which we just heard an elegant lecture about as well, and then schizophrenia at the bottom as well. And all of these kind of interplay to lead to this intermixture of depression as well as diabetes as well. So that's kind of a complicated way to look at it. Let's just talk about depression and diabetes. It's kind of a chicken and egg situation. Did depression come first, or did type 2 diabetes come first? They actually intermingle, and one leads to the other. And as Roger pointed out in his previous lecture, it may be that there's a common seed for that, and the common seed may be related to inflammation, to the macrophages, as well as to the excess fat deposits within the adipocytes as well. So diabetes or depression has been clearly shown to be an independent risk factor for the onset of type 2 diabetes. It is, if we think of it simply, it has been suggested that it may be because depression leads to bad behavior, if you will, in terms of increased likelihood of unhealthy behaviors like sedentary lifestyles, obesity, as well as smoking, and that may be the connection. Well, I think that is not the whole story. That's kind of like very superficial. There's actually more that goes along with depression as well as diabetes. And if you look deeper and dig deeper, there's also hormones that may be involved, and these may be counter-regulatory hormones that we know are involved in diabetes. And also the immune system as well as the inflammatory activation plays a big role in this intermixture of depression and diabetes as well. If you're a pictorial kind of a guy, here's a pictorial of all of this in this nice brief review. So if you start from the right on the pictorial, you say intra and interpersonal psychological stress, which leads to some of the physical and psychological disturbances like sleep and mood disorder, which could lead to depression. But it also plays a part in the HPA axis, the hypothalamus pituitary adrenal axis, which leads to counter-regulatory hormones, which I just mentioned. Also, it relates to the immune system, the macrophages, which through the liver leads to more of an inflammation kind of pathway leading to diabetes as well. So that's kind of the interplay of all of these pathophysiological mechanisms. So I talked about depression and diabetes being interlinked in many studies. Here's one of the study looking at prevalence of depression in people with diabetes. So if you look at people with diabetes, how many people may have depression as such is what this study looked at. The first part is diagnostic interview. So it's actually an interview. It's a diagnosis that is based on that. And then the second set of bars is a self-reported scale. Of course, that is bigger or larger in number than the actual diagnosis based on interview, right? But what is clear is either one of those, the blue bar is more than the green bar, about double, which is people with diabetes versus people without diabetes. So it's about doubly more prevalent. Depression is doubly more prevalent in people with diabetes versus people without diabetes, is what is clear from this study. What are the socio-demographic risk factors? So epidemiologically, who's at risk for having depression when they have diabetes? So here's a list. This list is quite similar to what you think of for depression, even without diabetes as well. People who are younger, low socioeconomic status, less education, being unmarried, poor social support, maybe female sex as well. But then the last two pieces, the longer duration of diabetes and presence of long-term complications, may be more specific for people with diabetes, and that has to be noted as well. If they have more complications, of course, they have a more likelihood to develop depression in addition to that. Here's another slide from the Diabetes Canada guideline, which talks about depressive symptoms versus depression. And if you want to look at the numbers, it's about 10% of people with type 2 diabetes who may have a clinical diagnosis of depression, but depressive symptoms may be present in about 30% of those people with type 2 diabetes as well. And this is not without any complication risk. People who have depression alongside diabetes, they actually have much more risk of complications. We're talking about macrovascular as well as microvascular complications of diabetes. So the kidney disease, the eye disease, the foot amputations, all of those are much more increased in people who have this comorbid depression as well as diabetes. And the question is, what leads to that more complications? It leads, the reasons could be multiple. They could be, if you look at pathophysiological mechanism, they could be that as well, but also non-adherence to medications as well as self-care approaches plays a big part in that as well. There's also the functional impairment, risk of complications and increase, but it also leads to then healthcare costs as well as risk of early mortality that is increased as well. So that's what is the downturn or the downside of having this comorbid condition that, as I said many times, just like our patient, Mr. Bernard, that we started with, goes unrecognized at times as well. So it's important to recognize depression, but it's also important to recognize this thing, this entity called diabetes distress, which is a more broader term in a sense, right? So diabetes distress is not clinical depression. It's despondency or emotional turmoil that goes along just having diabetes. And it affects caring for diabetes. It affects the need for monitoring and treatment. Also, the preoccupation with complications, that people think, oh, I'm going to have this kidney disease, oh, I'm going to go blind, right? So the preoccupation with the complications also leads to this diabetes distress. Of course, it affects various relationships. It could be sexual dysfunction, but also various other relationships from the mood as well could be affected. And all of these have been implicated in poorer diabetes outcomes. So we have this, two entities. Basically, we've talked about depression alongside diabetes, and then this diabetes distress alongside diabetes. It's very, very important that we look into or screen for these possibilities in each and every patient with diabetes as such, right? So the first recommendation from Diabetes Canada in every patient with diabetes is to look into this or screen for these. So individuals with diabetes should be regularly screened. They don't say what is the regular frequency of screening, but they say that every patient should be screened and then individualize how often do you want to re-screen as such. And they should be screened for both the psychological distress aspect, which includes diabetes distress. It also includes this term called psychological insulin resistance, which I'll try to go over in the next slide or two. And then fear of hypoglycemia is a major concern as well as they should be screened for psychiatric disorders. So not just distress, but also if they may have underlying depression or anxiety disorders, should be screened as well. And of course, we should ask about suicidality or self-harm as well within that recommendation, within that screening paradigm as well. So the question is, so how do we screen every patient with diabetes? These are two survey-based, self-report kind of survey-based scales that you can use. So the Diabetes Distress Scale, or DDS, or PHQ-9 for major depression disorders. So these two would screen for diabetes distress. The DDS would screen for that, and the PHQ-9 would screen for the major depressive disorders. And you can read the various features of the diabetes distress. It includes emotional burden subscale, a physician-related distress subscale. So that may have to do with how good-looking maybe the physician is or something. Or maybe it's more related to, how does the physician actually start blaming the patient? Oh, you brought this on, the stigma, right? It also may be related to that as well. And then regimen-related distress subscale and diabetes-related interpersonal distress subscale. And then in the PHQ-9, we have all the symptoms that we think about for depression, like the vegetative symptoms, the emotional symptoms, the behavioral symptoms, as well as the cognitive symptoms that are included in that subscale. Now, these are the two common used subscales. There's also others if you're interested, and Diabetes Canada scale says that you can use any of these depending on whichever you think is best for your patient or for your case. So diabetes-specific distress, you can use a PAID scale, PAID. I don't think it costs anything, but it has an acronym that is PAID. And then DDS, we already talked about. You can also do a quality of life scale, which is the WHO-5 scale. Or in the terms of depression and anxiety, we talked about the PHQ-9, but there's also the HADS as well as the Beck Depression Inventory that can be done as well. So at least do one of these for diabetes distress as well as for depression for every patient with diabetes is what is recommended. I talked about this term, the psychological insulin resistance, right? So what do I mean by that? So this is what that means, that when you talk about a patient starting on insulin, and insulin is one of the therapies that we use in diabetes, of course, there's other therapies in type 2 diabetes that we use as well. But sometimes when we bring the word insulin, it generates kind of this emotional response from the patient. What are those emotional responses? It is like the perception of worsening illness severity. So it's basically, this is the end of life or the end of the game for diabetes. That's what the emotional response that they think of as well. And then the requirement for insulin represents a personal failure to manage the illness. That is because they did not manage the illness as well, and that's why it's like a punishment for them as such as well. So that's not true. We know pathophysiology includes those 8 different organ systems, and we know that beta cell in the pancreas, we talked about the progressive nature of diabetes because beta cells keep failing over time. So it's not just their fault. It's actually the fault of the disease that there is a progressive nature of diabetes leading to insulin being necessary at some point. So it's important to realize and recognize that as well. Now I'm going to show you a couple of studies linking depression, diabetes to dementia or cognitive dysfunction as well, because that's another entity that is in the mix as well. So this is a study, nice study, looking at, this was in the archives of general psychiatry, looking at this interrelationship. And when you look at the hazard ratio, basically, there's a double risk of dementia in those people who have depression as well as diabetes. So diabetes and depression, that mix leads to more risk of dementia is what this study showed. And taking this further, so how much do one versus the other versus the combination lead to dementia is explained in this JAMA psychiatry study, which is that if you look at the DM kind of a hazard ratio, it's about 1.2, And then depression is 1.8 or so. So that's an 80% increase in relative risk of having dementia if you have just depression versus about 20% increased risk of dementia if you have just diabetes. But then the last column that you look at is the patients who have comorbid depression and diabetes. What is the risk of dementia? It's about 220 times, or it's more than double basically. It's 2.2 is what I should say for the hazard ratio. So it's more than double of that without people with depression and diabetes. So it's not just additive. It's actually more than additive that leads to dementia when you have this comorbid depression as well as diabetes. The question is, how is this all coming together? There are various pathways that may be linked. This is kind of a pictorial for that. It may have to do with amyloid beta deposition. It may have many different mechanisms or pathophysiology concepts may be interlinked causing this, including inflammation, including adipokines, which come from the adipocytes, the fat cells in our body, the oxidative stress, as well as other things that go along with it as well. So it's very common when depression and diabetes coexist, that dementia over time is a risk as well. This is a study looking at patients who have mood disorder with just excess body fat, right? So increased BMI without necessarily having diabetes as well. So just that independently also increases the risk of cognitive dysfunction, is what this study showed. And if you look at just the effect of diabetes itself without having comorbid depression, so even diabetes increases the risk of comorbid cognitive dysfunction over time, is what this study showed. That if you look at the people with controls, who's the green, the filled green, if you will, and then the open green is the people with type 2 diabetes itself. So type 2 diabetes people, when they are followed for 4 years, their cognitive impairment is apparent, as you can see from their information processing speed, which is the left graph, and then the right graph is attention and executive functioning is the right graph. So you can see that people with diabetes or without diabetes, how they differ in terms of their progression of that cognitive dysfunction. And this is regardless of having comorbid depression as well. Now, this has been put together like in a meta-analysis format. So if you look at people with diabetes versus without diabetes and the risk of Alzheimer's disease, this is a meta-analysis that was published a few years ago that suggests that there may be about a 50% higher chance of dementia in those with diabetes versus those without diabetes as well. So it's very common to have what we've discussed. So there's depression, there's cognitive dysfunction, dementia with diabetes, and there are various pathways that interlinked these, both from a pathophysiological standpoint, also from a clinical standpoint. We see this very commonly. So it's a very kind of depressing environment, right? We're talking about all of these coexist. So the question is, what can we do about it? What is the management? How should we approach this, right? So I talked about every patient with diabetes early on should have this team care approach where they see other healthcare providers, allied healthcare providers, in terms of people who have depression or people who have dementia. Maybe we need to expand that to mental health professionals as well. So this is a recommendation from Diabetes Canada in terms of that. The following groups of people with diabetes should be referred to a specialized mental health care. And who are these people? These are people who have significant diabetes distress, persistent fear of hypoglycemia, people who have psychological insulin resistance, or people, of course, if they have psychiatric disorders like depression, anxiety, or eating disorders, those are the people who definitely should be referred to a mental illness specialist as well. So then, when diabetes and depression coexist, or any of these other conditions are there, what are the therapies or what are the management approaches in terms of managing these conditions? And I'm not a psychiatrist, and I'm not going to fake that. I'm going to leave that to the experts in this room. I'm going to just go over broadly some of the treatment options that are recommended in the Diabetes Canada guideline. These could include cognitive behavior therapy, other forms of psychotherapy, also antidepressive medications as such as well. A prime example of cognitive behavior therapy is in that patient, for example, with fear of hypoglycemia. So of course, hypoglycemia is bad, we know that, but people, when they get one episode of severe hypoglycemia, what tends to happen is they start panicking every time their sugar goes to 5 or 6, which is in the normal range, right? Even then, they start panicking, oh, is this going to keep going down, or is it going to affect me? Is it going to lead to another severe episode of hypoglycemia? And in that kind of situation, maybe cognitive behavior therapy could be utilized. The other thing could be maybe play a role in addition to cognitive behavior therapy approach that is on this slide is maybe a use of CGM device in this patient as well, who has excessive fear of hypoglycemia. So the use of technology could be utilized potentially, because CGM, for those of you who may not be familiar, it actually tests the sugar every few minutes. And it actually it's not just one sugar in the morning, one sugar in the evening. It's actually continuous glucose monitoring that is now available and being utilized in certain patients. Of course, it's expensive and not widely covered, so that's the challenge. But in certain situations, in people who have severe fear of hypoglycemia, that may be, in addition to cognitive behavior therapy, that may be a good way to go as well. In terms of antidepressant medications, this is exactly from the Diabetes Canada guideline as well, that antidepressant medications should be utilized. They also go over which antidepressant medications may have bad metabolic effects versus not so bad metabolic effects. And so that's an important consideration when you're choosing your antidepressant. And of course, that can be combined with the CBT as well. So those are the management approaches for people with diabetes and coexisting depression as such. Of course, a lot of research needs to go into all of this. We don't have enough knowledge of how to treat, how to manage these patients. For example, some of the literature, if you look, what is the effect of diabetes therapy itself? We are saying some of the distress that happens is actually related to the fact that they have diabetes. So how do diabetes therapies affect that diabetes distress is kind of unknown. There's scant literature around that tackles that, but not enough to make a clinical judgment. For example, I'll show you this study, which is, as Roger pointed out, the polypill that everybody should be getting, which is exercise. So what is the role of exercise? This was a study of 50 patients with type 2 diabetes who had moderate level of depression at baseline coexisting as well. So a 12-week intervention was done with 10 CBT sessions. In addition to exercise, the 150 minutes, which is recommended weekly for every patient with diabetes, was included in that. And then they saw improvement in the severity of depression in this study, which was sustained to 3 months. So 50-patient study, kind of a pilot study, 12-week, and some improvement in depression severity. How about treatment for diabetes? Does that affect depression or kind of this distress or not? Again, scant literature. This is one of the studies. The diabetes-free is the first, the number one, and then diabetes without OAAs means without any anti-hypoglycemic agents, without any diabetes therapies as such. There was an increased risk of bipolar disorder in this study, versus if people with diabetes were given diabetes therapies. In this study, it was suggested that the risk of bipolar disorder is much less, maybe similar to diabetes-free. But again, this is wishy-washy and not very high level of evidence, I will say. And so we need to study this much further with oral therapies as well as diabetes therapies, especially the newer diabetes agents. Roger pointed out liraglutide or Victoza and its utility potentially. Here's another study looking with the same agent, liraglutide, on reduced amyloid and inflammation within the brain as well. So if you look at the black versus the checkered kind of a row, you see the improvement in the reduced amyloid as well as inflammation that was seen in this study. The other thing is use of technology may impact the diabetes distress as well. I pointed out the CGM, right? There's also insulin, and how do we increase or titrate the insulin? That plays a role in terms of the patients, how they react in terms of their stress as well. So here's a study that we did with a tool, which is a web tool. So this is just patients who are newly started on insulin. They go on this website and they enter in, my sugars are this, my insulin dose is this. What dose of insulin should I take now is the question that we are looking into. And so we compared this web tool, which we had run an algorithm for, versus the usual care, which is through a diabetes education, a person interacting with the patient and telling them go up 2 units, go up 4 units is what we compared it to. So what I'm showing you here is that basically every clinical parameter that we looked at was the same. A1C was the same. So why am I showing you this is because of this part of the study, which we looked at patient satisfaction scores in this randomized trial. And when we looked at this, we actually found that fear of hypoglycemia score and various aspects of the diabetes distress score were actually in favor of the technology rather than a person interacting with the patient as well, which was kind of surprising to us as such. And some of these, as you can see, were statistically significant as well. So again, technology can also come or help rescue the situation. Maybe if we build technology that is foolproof, it may actually help with diabetes distress for certain patients, certain individuals as well. So I'm just going to end and summarize, and I'll be happy to answer questions after this. So what we've discussed, the first part we discussed is that psychosocial interventions and a team approach should be adopted for every patient with diabetes. It's necessary. And don't wait until 10 years of diabetes. Start from the beginning of diabetes. That's when this team approach needs to be adopted for every patient with diabetes. And then the second piece is that every patient with diabetes should be regularly screened for diabetes distress with that DDS, or for depressive disorders with that PHQ-9 kind of surveys. And then if you find any of those, then what we need is professional help. And then we need our friendly psychiatrists, first of all, to be available to help with either CBT or other pharmacotherapy approaches as well. So that's where I'm going to end. I'm just going to say that, again, going back to our patient, if we actually intervene in Mr. Bernard and many other patients who get diagnosed early on with diabetes and follow these simple kind of 3 management approaches, we can actually prevent that diabetes complication of amputation that was shown in this case, as well as a potential malpractice lawsuit that resulted from that as well. So thank you.